I'm recently appointed consultant at UCLH, and I'm going to talk about patient-centered outcome measures in perioperative medicine, which is a sort of particular interest of mine. So I'll talk about what we currently measure in perioperative research and what I sort of think we should be measuring, and the slightly thornier issue of kind of how we should be doing it. And most importantly, kind of why all this comes about. So the kind of why, I think, is fairly straightforward. So you might have heard this quote before. There is an obvious, contradiction in the idea of a successful operation but a dead patient at the end of it all. And the kind of bigger side of why patient-centered outcomes are important and why outcome measurement as a whole is important, I think, is encapsulated by this character. So Lord Kelvin, who was around at the end of the 19th century, and looks like a fairly austere bloke from his photos that I've been able to find of him. He was very into measurement and said that if you can't measure things and you can't put numbers on things, then you can't improve things. And I think we all know that from our sort of audit and QI work in the NHS. And he was the first person to sort of really encapsulate this idea. So let's have a think about the sort of traditional perioperative outcomes that we measure. You've got outcomes that I think we're all pretty familiar with, that we sort of think of as clinical outcomes. So things like post-operative mortality and post-operative complications, and whether or not the operation has been a success. Now, these are things like, obviously, whether a patient survives for 30 days after surgery, things like post-operative cardiac events, post-operative kidney injury, those sorts of things. And then we've got the other sort of big category of outcomes that we currently measure are resource use outcomes. And that's really for two reasons. It's firstly because the amount of time a patient's in hospital and the amount of resources used in looking after them around the time of an operation is a pretty good proxy for how smooth and uncomplicated their recovery was. But it's also directly related to how much it all costs. So managers, and particularly in countries that spend an awful lot of money on healthcare, like the United States, for example, are interested in the costs of care. And these outcome measures have obviously got a lot of advantages. They're important to patients and clinicians. They're fairly easy to define and recognize in most cases. They provide sort of good targets for quality improvement. So, for example, cardiac events after an operation were targeted sort of 10, 15 years ago with the idea that maybe perioperative beta blockers might reduce cardiac events. And obviously, they help identify targets for cost reduction as well. So you'll be aware that ERAS programs, although they haven't been able to show a mortality benefit, do show a reduced length of stay. So that's kind of music to the ears of managers and also patients and clinicians, getting patients out of hospital quicker. But there are also some disadvantages to these outcome measures. Firstly, the fact that they're all pretty short term. So we are very focused on what happens in hospital, what happens up to 30 days post-operatively, but we're often a little bit sort of neglectful or forgetful possibly about what happens beyond that. We're also quite good at measuring things that are possibly not actually important per se to patients or clinicians. So things like asymptomatic troponin rises. There's a lot of interest in myocardial injury after surgery, but what it actually means is difficult to correlate. There are also quite a lot of these outcomes that are fairly subject to clinician judgment. So when you judge a patient to be in acute left ventricular failure, or whether you judge an arrhythmia as being significant or not, if someone has a 10-second run of atrial fibrillation on a monitor and then goes back into sinus rhythm and that's the end of it, that's obviously a bit different from a sustained hemodynamically compromising arrhythmia that needs treatment and keeps them in hospital a bit longer. Similarly, it's well documented that lots of DVTs are asymptomatic and never get picked up. If you go looking for them, you may find them, but the ones that sort of are clinically manifest are maybe only the sort of tip of an iceberg. And I think the biggest disadvantage of these traditional outcome measures is that they're fairly rare events. If you're talking about hip fractures or emergency laparotomies, then mortality and post-operative complications are obviously a big deal. And we look at those very carefully. But if you're thinking about rather more routine operations like laparoscopic cholecystectomies or hernias or varicose veins or any number of things you care to mention, there probably isn't enough post-operative mortality or indeed post-operative morbidity to really use that as a quality metric. So if you're only looking at post-operative complications and only looking at length of stay and only looking at post-operative mortality, I would argue that those measures aren't really enough to tell you the kind of full gamut of patient recovery from those operations. And so we come to patient-centered outcomes, and the whole idea of patient-centered outcomes is to reflect what we think is important to patients in a whole load of different ways, not just in the sort of short term immediately after surgery, but for the rest of their lives going forward in the medium to long term. And there are various ways of looking at this. So health-related quality of life is a commonly used metric for assessing how well a patient has recovered from surgery. Looking at a patient's functional status, so how quickly they get back to being able to mobilize, things like eating and drinking, those are all things that we also like to measure. Getting back to a patient's usual life roles, so whether that's time off work or getting back to carer roles if they've got family carer duties, as it were. Things like their psychological and emotional well-being are obviously an important component of patient-centered recovery. And whether sort of encapsulating all of these things together, whether they're better or worse than they were before their operations, whether they regret having the operation or whether they're satisfied with the results overall, all of these things sort of play into this whole idea of patient-centered outcomes. And this is all kind of about, are we getting patients back to what they were doing beforehand, happy and their usual sort of life roles, or are they miserable and unable to get back to all the things they were doing beforehand? But this is a difficult thing to encapsulate in a particular outcome. There's a very nice review that was published in Anaesthesia at the start of the year, which I just wanted to bring to your attention, that sort of conceptualizes all this as a kind of hierarchy, if you like, of outcome measurements. So you can look at fairly simple to measure biomarkers, for example, a creatinine rise after an operation. And you do that because you're interested in a clinical diagnosis. So, for example, post-operative acute kidney injury. And one of the reasons you're interested in that diagnosis is because of the implications it has for patients being in hospital and recovery and the costs of care. So healthcare utilisation measures that I've already touched on. But then the sort of patient-centred outcome at the end of all that may be very variable. You can get patients who have acute kidney injury, end up on a filter, it costs lots of money, but they get better completely and kind of no lasting sequelae from all that. Or you might have a patient who never recovers from their acute kidney injury and ends up permanently on dialysis 3 times a week as a result of this. So the kind of overall patient-centred outcome may be profoundly different, even if your biomarkers at the start have been the same and your clinical diagnosis has been the same, and 2 patients who've ended up on renal replacement therapy. And I just compare this with the what's kind of traditionally used in chronic disease measurement, the idea of impairment, which is, for example, you've had your foot amputated, leading to a disability, which would be, in this case, not being able to walk. And then the handicap is the life roles that stops you fulfilling. So if you're a marathon runner, you wouldn't be able to run marathons, for example, or more likely, if you're unable to walk, you wouldn't be able to do various kinds of jobs, for example. So it's this sort of idea of a hierarchy of outcomes, and it's only by really sort of measuring all levels of the hierarchy that you get a full picture of what's important to patients, not just in the short term, but in the long term. This is an idea that has been sort of flagged as being important within the NHS. This is from a few years back on the NHS website. So this is a direction that the NHS is going in more generally. And just to sort of pick out the important bit of the blurb on all of that, what they've said is that patient-centered outcome measures involve putting patients, their families and carers at the heart of deciding which goals are most valuable, rather than clinicians deciding what is best. So it's all about patient empowerment, doing things that matter to patients, and not just what matters to clinicians. Now, my interest in all this stems from my research work when I was a research fellow a few years ago under Ramani's guidance, and a project that I was involved with called Patient-Centered Outcome Measures for Major Surgery. And the question we were asking in this study was, which outcomes matter most to patients having major surgery? So it's a pretty simple question, but one which, obviously we don't have a short and simple answer to. Now, the idea of this study was that it was going to be a mixed methods prospective study using both quantitative methods and qualitative methods. So a quick quantitative survey and then some in-depth semi-structured phone interviews to explore stakeholder views about important outcomes after major surgery. And when I say stakeholders, there were basically two angles to this. There was the patient and carer perspective, so people who'd had major surgery, and there was the perioperative clinician perspective, so people involved in looking after patients having major surgery really at any stage of their journey. So surgeons, anaesthetists, recovery nurses, GPs, lots of allied health professionals, you name it, anybody involved at any point of looking after patients after major surgery. And the idea was going to be a short survey, as mentioned, and then some qualitative, more in-depth phone interviews with a much smaller sample of the kind of main sample. Now, for various reasons, the qualitative side of things kind of fell by the wayside. So it ended up being really just a survey study looking at what patients and carers and clinicians felt was most important in terms of perioperative outcome measures. And this was an NIHR portfolio adopted study. We rolled it out across 31 sites in Wales and England, some of which I had to look up on a map, but that's where they all were. And the survey was really pretty simple. We collected a bit of demographic information, and then we asked people to rate on a scale of 0 to 10 the importance of the following outcomes after an operation. And you'll see that there are these sort of traditional clinical outcomes in there. So post-operative mortality down at the bottom, surgical success at the top, and post-operative complications, numbers 5 and 6. And then there were also these much more sort of patient-centered, getting back to normal daily activities, being comfortable after the operation, getting out of hospital as quickly as possible. And all of these things we asked patients to rate on a scale of 0 to 10. Now, we ended up with about 4,000 responses to this survey from the various different centres that we recruited people from. About 2,500 of those were patients and carers, and about 1,500 were clinicians. And you will see from these numbers that the agreement about the traditional clinical outcome measures that I've already talked about was very, very high. And these were almost sort of universally, so these are the proportions of patients and carers and of clinicians who rated each outcome as critically important, and we define that as scoring it as 8 out of 10 or more. And you can see that more than 95 to 100% of people for almost all of these domains felt that these were critically important outcomes, and that was the case both with patients and carers and with clinicians. So pretty good agreement across the board, both in patients and carers and in clinicians, that these are really important outcomes, and yes, we need to be measuring them. When we come to the patient-centered side of things, though, you'll see that those differences between patients and carers and clinicians start to get a little bit wider. So the overall rating of post-operative comfort in terms of importance was a little bit lower in both groups, but you can see there's now a sort of 5% difference between patients and carers and clinicians, with patients and carers being more interested in that as an outcome measure than clinicians were. And when you get down to the getting back to normal activities as soon as possible and getting back to getting out of hospital as soon as possible, these differences open up even more. And you can see that the overall ratings are lower in both groups, but the difference is greater. And this graph shows you really exactly the same thing. The clinical outcome measures, which are the ones with the green circles around them, very high ratings in terms of their importance, very high agreement between patients and carers and clinicians. So everybody is unanimous that those are really important outcomes, but the patient-centered ones are rated much more highly by patients and carers than they are by clinicians. which we thought was an interesting finding. And then there was a final question to the survey, which was a free text question saying, are there any other outcomes that you think are important after an operation that we haven't mentioned above? And the responses to that were interesting as well. So about a third of each group, roughly, filled in a sort of free text response to this. And although what the sort of main themes to emerge from this weren't really what you might think of as outcome measures per se, what they did reflect was lots of aspects of patient experience. So the 5 things that sort of really came out of these free text responses were the importance of perioperative information, good communication, staff attitudes and behaviour, access to support and follow up after discharge, and the post-operative care environment. And you'll see again, if you look at the top 2, there's pretty good agreement between patients and carers and clinicians that information and communication are very important. So similar, these were themes that came out in a similar proportion of comments between patients and carers and clinicians. But if you look at things like staff attitudes and behaviour and access to support and follow-up and the standard of the post-operative care environment, those are things that matter much more to patients and carers than they do to clinicians. So again, these are sort of discrepancies in patient experience measures, if you like, that we didn't really know about before, but which these free text comments flagged up. So the conclusions from all of this were a kind of reassuring consensus that traditional post-operative outcome measures that we measure routinely already are very important to patients and carers and clinicians, and everybody is interested in those. But also kind of highlighting that clinicians maybe don't value the patient-centered outcome measures quite as highly as patients do. And similarly, that clinicians don't value the softer patient experience measures that still matter to patients. So where does this leave us? Well, measuring patient-centered outcomes is not a straightforward nettle to grasp. So there are lots of ways of measuring patient-centered outcome measures. Lots of them are sort of multi-dimensional, and some of them just concentrate on one specific area of post-operative patient-centered well-being. So health-related quality of life, which I've already touched on, there are lots of tools for measuring health-related quality of life. They broadly divide into those that are generic measures of health-related quality of life. In other words, they can be used in any kinds of patients. And then there are others that are much more disease-specific. So WOMAC, for example, in Oswestry, WOMAC stands for something like Western Ontario measurement of, I can't remember what the AC is. Anyway, they're both to do with back pain, so patients with back pain and measuring the kind of impact on their lives of living with back pain. GI-QLI is the gastrointestinal quality of life index. So this is patients who've had bowel surgery or have inflammatory bowel disease or other chronic bowel pathology, and the impact of that on their quality of life in terms of their health. Functional status and dependence levels, you're probably all reasonably familiar with things like the Duke Activity Status Index, the Barthel Index, which is used commonly in stroke patients and for other sort of neuro outcomes in the long term, the Karnofsky Performance Index, which is used in cancer patients. Then there are things like objective functional capacity measures, which again, you're probably reasonably familiar with, things like CPEX measurements and 6-minute walk tests and timed up and go tests. And then there are measures of what roles patients can fulfill. So can they work? Can they fulfill their carer duties and obligations? Are they able to perform the kind of hobbies and pastimes and extracurricular things that they like doing before their operations? Where do they live? Do they return to their normal home or their normal place of residence, or do they have to go to an increased level of care kind of residence? The psychological and emotional aspects of patient outcomes in the long term are obviously something that that are of interest to lots of healthcare providers in the medium to long term. And then, as I mentioned, the kind of overall, have things got better or worse? Are they satisfied, or do they regret their decision to have surgery? And there are various ways of measuring those things as well. So this is a complicated area of outcomes to measure. Just to give you two sort of examples of scales that are used, the one on the left is the EQ5D, which is the European Quality of Life 5-dimensional survey, and you probably can't read that because it's all printed very small, but it measures kind of how much patients are able to do in terms of mobility, self-care, their usual activities, pain and discomfort levels, and anxiety or depression. And then the Duke Activity Status Index on the right, which is looks at various kind of activities and what patients can or can't do, and scores those all, and you toss up the score to get a sort of overall score. So these are, health-related quality of life measures that allow you to put a number, if you like, on kind of how good a patient's health-related quality of life is. But these are difficult things to measure because they're often complex, they're often multidimensional, they're quite time-consuming and resource-intensive to measure. They're quite subjective. So one patient who's got objectively the same level of mobility, for example, or the same level of pain as another patient may well score their symptoms differently. And sometimes they're not all that intuitive, and there are often circumstances where patients and carers might need a bit of help completing it, with a clinician explaining sort of what the whole thing is getting at to them. And then there's the kind of thorny issue of what tool are you going to use? You've got to use one that's well validated. When are you going to use it? Do you use it on the day post-operatively, or do you use it 6 weeks post-operatively, or 6 months post-operatively, and so on? And how often do you use it? Do you track scores over time, or do you just do a kind of baseline and then a post-operative follow-up? Do you administer it face-to-face? Do you do it over the phone, online, and so on? And the data that you get out of these, you can often end up with a mixture of quantitative and qualitative data, which is obviously quite resource intensive to get to analyze. And then what about patient experience? Well, patient experience is similarly multidimensional, but there's a lot of interest in patient experience because it's been defined as kind of one of the 3 pillars of quality in healthcare, if you like. So healthcare quality was defined in the Darcy report, I think it was like 8 or 10 years ago, as being made up of the kind of clinical effectiveness of care. In other words, are we providing care that does what we hope it's going to do? Are we providing safe care? And are patients having a good experience of the whole thing? There are lots of ways of measuring that. Again, there's no kind of one nice, simple, easy way to do this. But it's an area of increasing interest because there is a lot of evidence that positive patient experience is positively correlated with high levels of clinical effectiveness and good patient safety. So the better your care in terms of its clinical effectiveness and its safety, the better the patient's experience is also likely to be. And those of you who've worked at UCH recently will no doubt be familiar with the trust values of safety and kindness and teamwork and improving, and the whole idea that patient experience is important in all of that side of things. So I feel like I've left you with more questions than answers at the end of all this, but the kind of 2 take-home points that I would try and leave you with from all this is the kind of why do we need patient-centered outcomes? Well, firstly, because traditional outcome measures don't really capture everything that matters to patients and don't give us a kind of full picture of the quality of care that we're providing. And as I mentioned, I think that's particularly true in the routine surgery that maybe doesn't have high rates of mortality and high rates of post-operative complications, because if we're only looking at clinical indicators like post-operative complications and post-operative mortality, it's very difficult to pick up whether we're providing high quality care. And secondly, how do we go about collecting patient-centered outcome measures? Well, I would argue that, as with all outcome measurement, if you make things too complicated, it's very difficult to make sense of the data. It's very difficult to actually get people to collect the data. And like everything in healthcare, the more we can make it easy for patients, the more we can make it easy for clinicians, the more likely we are to be successful. So my interest is in using UCLH MyCare, which is linked up with Epic, to collect some sort of basic online metrics, but I recognise the shortcomings of online data collection and the fact that that may not suit all our patients. So I don't think there's an easy way to do this, but I think having a quick and easy starting point and then fleshing that out is probably the way to go. So there are a couple of opportunities to get involved with collecting patient-centered outcome measures. If this sounds like the sort of thing you might be interested in, we're looking to collect patient-centered outcome measures for major surgery on Westmoreland Street and the new T6 PACU units as they start to roll out, and block room patients. And Damon Camming is particularly interested in this as well. So they are starting to collect some patient-centered outcomes for block room patients in terms of sort of just simple feedback from how their experience was. So anybody that's interested in either of those, please do get in touch with me. That's my email address on at the bottom there. Otherwise, I will stop there, and I'm happy to take any questions.
Fantastic. Thank you very much, Ollie. Great talk. Apologies for my coffee now. I thought my mic was on mute. So I have a question I'll start with, if it's okay. So I'm going to really put you on the spot. If you had a budget, I was going to say a limited budget. If you got a budget and you had to choose one particular outcome that you thought was going to make a big difference, either whether it's sort of improving care, whether it's just improving satisfaction in general, which one of them would you go for?
Oh, that's a tricky one. I mean, I think the EQ5D is a pretty good one to start with, because I think it's well validated. It's not that onerous to collect, and I think having a number at the end of it all that you can firstly compare with other centres, although that's subject to the variations of sort of how things are measured and when and so on. But I think if you've got something quantitative that you can then track over time, that's a kind of a good place to start within your institution, as it were. I think it's another sort of thing you need to decide pretty early on is, what patients am I going to measure this in? So if you're only interested in one group of patients, you may say, if it's, I don't know, emergency laparotomy care, for example, you might say, well, I want to use this particular tool that is validated for patients having major bowel surgery, and that reflects their quality of life going forward. But if you're trying to measure emergency laparotomies and major cancer surgery of various stripes and, you know, joint arthroplasties or whatever, so you've got quite a lot of different surgeries kind of carried out for different reasons, then that makes things a little bit harder. And that's when I think you probably need to sort of take a bit of a step back and say, well, I'm going to use something a bit more generic that may not capture the full richness of, for example, what's a patient's pain level or mobility level like, or what can they do 6 months after a hip replacement, but does give me a kind of overall number that I can then sort of keep track of going forward and get a feel for whether things are getting better or worse in terms of patients' outcomes in the long run. So yeah, EQ5D I'm quite a fan of, but no simple answer.
So would that be what you would be voting for going into the MyCare app, or are you going to try and target it based on the type of operations?
I think I'm not very familiar with what MyCare can do, and I think an awful lot of this comes down to actually not what you want to collect, but what patients can and will fill out. It's no good saying EQ5D is, you know, the thing we want to collect, and you send out a reminder to patients 6 weeks post-op and you get a 10% response rate, because it's too long, too difficult to understand, you know. So I think pragmatism is the kind of key guide in all of this. And I think the satisfaction and regret stuff is actually quite a nice sort of starting point for that, because if you can give people a couple of very quick, simple questions, maybe with a Likert score saying, are you satisfied with the results of your operation? Very satisfied, quite satisfied, not very satisfied, totally dissatisfied, wish I'd never had it. And it takes them 2 minutes to fill out, and it's kind of like doing a TripAdvisor review or whatever, but without having to answer more than 2 or 3 questions, then that may be a good place to start. The tension with all of these things is that if you make things too simple, you get data that is just not rich enough to make anything of. If you make things too complicated, then you don't get enough of it, and patients half complete it and then they give up halfway through, and so on. So I'm sure all of you will have had that experience with gathering data in the perioperative context generally. But and I think probably the way to, a bit like the introduction of EPIC at UCH, starting simple and then building on top of it is better than starting ambitious and then having to scale down. But yeah, it'll be a work in progress.